So I would like to review some of the data about prediction of risk of recurrence and also even chemotherapy benefit for stage 2 and 3 colon cancer. And we'll mostly be reviewing the data from a number of adjuvant clinical trials and the results from the Genomic Health Oncotype test that shows us how to judge some of these risk issues. So when we're dealing with stage 2 colon cancer, I'd like to begin with the stage 2 situation. You know, most people are going to be cured by surgery alone, and it would be really helpful if we knew who was going to be cured and who wasn't going to be cured. Unfortunately, we can't, and on top of that, the data are not great that are out there, but from what we can see from various studies, the benefit of the chemotherapy, or at least fluoropyrimidine monotherapy, is pretty small, and it has some toxicities. So we'd like to be able to assess the risk of recurrence in a better way than just saying it's stage 2. I mean, after all, we've spent the last 20 years learning a lot about molecular biology, about, the way cells behave, and it would be really nice if we had some 21st century technology, or at least late 20th century technology, instead of going back to 19th century microscopy. So that is what the Oncotype test attempts to do. And furthermore, for stage 2 colon cancer, I mean, if you look at the AJCC staging and the different stages, stage 2A, B, 3A, B, and C, you can see here that there is a fair amount of variability between the survival of the patients. So you have a 5-year survival of 85% for 2A, but stage 2B is actually a little worse, according to the AJCC staging, than stage 3A. So this is a situation where more data can be helpful to both us as physicians and the patients in trying to decide the relative merits of receiving treatment or not. And just to kind of recall to everybody's mind what's been happening in adjuvant therapy of colon cancer, there was a long time where people didn't even believe that chemotherapy worked until the NCCTG trials with 5-FU and levamisole, and then took about a number of years to show that leucovorin was good and levamisole wasn't really necessary, and 6 months was equivalent to 12 months. I'm sure some of you remember when we used to treat people for a year with adjuvant therapy. So, and then followed by the EXACT trial with capecitabine, and then Mosaic and the NSABP data using Folfox and Flox therapy, the use of oxaliplatin. So the NCC guidelines list a wide range of acceptable management, observation, 5-FU single-agent fluoropyrimidine with FU leucovorin or capecitabine, Folfox in high-risk patients or clinical trial. And the estimated benefit for adjuvant therapy is 25 to 35%, relatively speaking. And based on some guess, or the estimated percent of patients receiving adjuvant therapy in stage 2 is about a third of patients. And you can see here that most of them receive Folfox and few of them monotherapy with a fluoropyrimidine. So how can we guess? How can we estimate? What can we use to help make a recommendation to our patients? So you can see here that there's some, the things that we use are really kind of pretty soft endpoints and soft markers for recurrence. Bowel obstruction or perforation, T-stage, number of nodes, and then things like grade, lymphatic, and vascular invasion are also very variable in terms of the way they're reported by pathologists and how they're assessed by pathologists. So again, we're kind of left trying to advise patients on their risk of recurrence without having great tools. And of course, we're always trying to benefit the risk versus the toxicity and the absolute treatment benefit. So as we begin to develop biomarkers for risk in stage 2 colon cancer, these are things that we'd like to really know. What's the level of evidence? Is it based on prospective trials or not? How are the tests standardized and are reproducible, and they're done in CLIA-certified laboratories? And how useful are these markers in terms of the magnitude of risk, and if it's clinically useful or not. So if we look back as, for example, selecting tumor grade as a prognostic factor, if you look at all these studies, that's kind of gotten into literature as being something that's pretty predictive, but a number of retrospective studies from these institutions have suggested that there is a benefit based on tumor grade, but these tend to be on all stages, and a lot of them are heavily weighted towards stage 4, which probably does include some level of tumor grade being prognostic. But if you actually break out the stage 2 patients and you have a much smaller list and a much smaller number of patients, you can see here that the hazard ratio for the high versus low grade is only of borderline statistical significance in some cases and frequently not associated with risk at all. And not to mention the fact that these are kind of done by expert pathologists, and they may not reflect the variability in terms of pathology reading in everybody's hospital. So in the PTAC study, PTAC-3, where they actually looked at a multivariate analysis, you can see here that grade 3-4 did not really give any additional prognostic information, whereas age and MSI were statistically significant for stage 2. In stage 3, the grade may be a little bit more predictive. And another one is lymphovascular invasion. So again, here's one study that was done by 6 GI pathologists, and there is a low concordance statistic between the way it's being read by different pathologists, and even using immunohistochemical staining to better outline the lymphovascular stroma, there isn't a big improvement. So that brings us to the Oncotype DX colon test, and this is a DNA test based on being able to extract the DNA from paraffin-embedded and formalin-fixed tissue. So this is something that's readily applicable to the way the tumor specimens are processed today. And as you can see here, there were some developmental studies, the early NSABP trials in the Cleveland Clinic cohort, and then the developmental studies, NSABP, CO4, and CO6, that went into the selection of the 12-gene panel and the standardization. And then it was validated in the Quasar study and the CLGB adjuvant trial 9581 with monoclonal 17-1A that was called Panarex at the time. And then more recently, the data presented at ASCO, which I'll get to in a little bit, shows the data for the benefit of oxaliplatin in NSABP CO7. So here's the 12-gene Oncotype DX score, and you can see the recurrence score uses this regression formula, and it's based on some stromal genes, some cell cycle genes, and some reference genes. And when you put that into the equation, you come out with the recurrence score, and it gives you the graph that we're going to see in a moment. And this has been published in JCO, the validation of this test, based on the Quasar study. So the Quasar study was enrolled, took 10 years to do, and it was mostly in the UK. It was conducted by the MRC of England. And basically, to be eligible, you had to, the doctor said, I don't know what to do with the patient for adjuvant therapy. So it actually included both stage 2 and 3, but was 90% stage 2. So if you look at the resected stage 2 patients, they were kind of randomized to observation versus adjuvant treatment, but not all of them got 5-FU leucovorin. They didn't always get it on the same schedule. It's a little bit, the treatment is a little bit mixed bag, and some people got levamisole as well. But the study did show about a 3 to 4% absolute benefit for adjuvant 5-FU leucovorin in stage 2 colon cancer, and that's kind of the largest chemotherapy trial that is mainly stage 2 to date. So again, applying the the DNA extraction and the 12-gene score, as we showed in that formula, to that population in the Quasar study, comparing patients for surgery alone. There were 711 samples, and this is the regression curve with the 95% confidence intervals that shows the risk of recurrence at 3 years based on the recurrence score, which goes from 0 to 70, where at 0 you're at about 9%, and at 70 you're kind of up in above 25%. And the other thing I just wanted to mention here is mismatch repair deficiency. So MMR deficiency or microsatellite instability are two ways of measuring how the one particular factor that relates to tumor genesis and prognosis, and that is whether you have a normal system for fixing DNA mistakes with mismatch repair enzymes or you don't. And the way that you can determine this, in most hospitals, people do an IHC test for these enzymes. So these are the mismatch repair enzymes, MLH1, MSH2, and this shows you what the staining is when it's positive and negative. And there are 4 MMR enzymes that they can stain for, and that can then be confirmed by a PCR test. The PCR test is looking for pieces of DNA. So when you have mismatch repair deficiency, you land up with microsatellites. Your DNA is more unstable, and you land up with little pieces of DNA. And you can see this on this gel. When it runs out the gel by the size of the DNA fragments, you can detect whether microsatellite instability is there. So this would be an MSI high tumor, and this would be showing here, for example, a mismatch repair enzyme deficiency. This is usually, at least in our hospital, used to confirm that. So IHC for MMR proteins and PCR for MSI detect 2 manifestations. It's the same tumor biology. Mismatch repair deficiency is the same as microsatellite instability high. And otherwise, we call it mismatch repair enzyme P, or for proficiency. And this is the people who have mismatch repair enzyme deficiency, somewhat counterintuitively, do quite well. So we see about 15% of stage 2 have mismatch repair enzyme deficiency, but there's a very low recurrence rate for these patients even without treatment. And this is showing the results in 287 patients, and you can see that these guys do really well, better than 90% survival anyway, as opposed to the stage 2 patients, stage 2 and 3 patients that have normal mismatch repair. So about, again, 15% of stage 2 and maybe about 8% of stage 3 have this situation. And certainly for stage 2, this group does very well without treatment, and probably treatment is not really necessary. So if we go back to the Quasar trial, these 600 patients that are then analyzed, you can see here that on multivariate analysis, for patients treated with surgery alone, the recurrence score has a very significant p-value with a hazard ratio of 1.6 per 25 units. Mismatch repair deficiency is also quite powerful, and the T-stage, T4 versus T3, is also quite powerful, whereas these other tumor grade nodes and lymphovascular invasion are much less helpful. And so the Oncotype DX test kind of takes these into account and gives you 3 curves when you send this for the stage 2 patients. So here's the way the recurrence score performs for patients who have mismatch repair deficiency. So even with a very high recurrence score, the risk is pretty low. And most of us would say these patients really don't need treatment. And for patients with T4, the risk is really quite high, starting at around 20% and going up to 45%. And so most of these people are going to be treated. But for the group in the middle, your average kind of stage 2A patients that have T3, N0, and are mismatch repair proficient, that's about 3/4 of all the stage 2 patients. This is the curve that can help us tell the patients what their risk of recurrence is. So again, this is the risk of recurrence at 3 years based on the recurrence score. And as you can see, it goes from about 10% up to about 30%. with the score running from 0 to 70. So again, in the Quasar study, for the people who did get the treatment, it's about a 20% relative risk reduction. So if you take their risk and then put a 20% treatment benefit on top of it, you should be able to tell a patient how much benefit they might get from getting adjuvant chemotherapy with a fluoropyrimidine single agent. And if they come out to have a 25% risk, then their risk would be reduced to 20%. And if they had a 10% risk, then they would reduce their risk to about 8%. So about 20% relative risk reduction with a single agent fluoropyrimidine. And so one way to look at this is just to take 30 as the dividing line, where the recurrence score here predicts a 15% risk of recurrence at 3 years, and saying if it's less than 30, then they would have less than a 3% absolute benefit, and those people might not be treated, but then again, you can always discuss it with the patient and see if they think it's worth it for them. And the people who have greater than 40 would have a 4 to 6% absolute benefit. So those were people that potentially would be higher risk, and we would perhaps recommend that they get treated. So we're going to see some other cohorts later from the CO7 data, and again, we're using these same cutoffs. Less than 30 being low risk, 30 to 40 intermediate risk, and greater than 40 high risk. And in the JCO paper in 2001, you can see how this plays out in the Quasar data, that here's the surgery group, and then here's the treatment group. And if you look at the low risk, the intermediate risk, and the high risk group, you get more benefit that's proportional with the use of the chemotherapy. So that's exactly how we would expect this predictive test to perform. So the second study that looked at how the Oncotype DX test would work is the CLGB 9581. That was a stage 2 trial using monoclonal antibody 17-1A, or edrocolimab, that was also known as Panarex. Amazingly, this drug was actually approved in Germany based on a study and was sold for a few years before the study was negative, and then the drug was taken off the market. But in this trial, and I don't know if any of you participated in the trial, I did, the way it worked is that basically most stage 2 colon cancer patients at the time were getting treated. So the people we enrolled on this were people that we thought were better prognosis, and we figured maybe we'd get, or they were older and they could tolerate a monoclonal antibody. So it was there was a lot of patient selection, and it also excluded specifically T4B, obstruction, perforation, and positive margins. So high-risk patients were excluded systematically as well. And there were 1,738 patients enrolled. And as you can see here, if you compare the demographics of the CLGB trial compared to the Quasar trial, the percent of T4 patients is only 6% compared to 15%. There's a lot more mismatch repair deficiency patients here, 50% more, and that's without people even knowing what they were doing. So just by clinical features, we were picking those out, and then older age patients because we didn't want to give them chemotherapy. And, because of the surgical practice, there were fewer that had fewer than 12 nodes examined and so forth. So the recurrence risk for this study was only, for 5 years, was only 15% compared to 22% in the Quasar. So again, it's a lower risk patient population with more MMR deficiency patients. And again, if you do this multivariate analysis, again, the recurrence score comes out to be a very powerful and the most powerful predictor for who's going to recur in this trial as well. Here, the T stage wasn't that helpful. MMR was not statistically significant as well. And so in this trial, applying the Oncotype DX and multivariate analysis shows that that is a good predictive test and a lot better than anything else you might pick out. When you do a three-way multivariate analysis using just these three things, the recurrence score, the deficiency, and the T4, then the MMR does come out to be statistically significant. And The recurrence score identified 22% of patients with average risk of recurrence at 5 years in the T3 MMR proficient patients. So again, using those cutoffs, you can see here that 13% fell into the low group. 44% fell into the low group, and they had a 13% 5-year recurrence, 33% into the intermediate group was 16%, and 22% had a 21%. So this is a group here that even in this pre-selected low-risk group are still high risk for recurrence, still have a 21% 5-year recurrence rate, and could potentially benefit from the use of chemotherapy. So again, in this way we might look at this kind of paradigm today, if you have a resected stage 2 colon cancer patient, you're going to look at the T stage and the MMR status. If they're T4, then they're going to get chemotherapy. If they're T3 and MMR deficient or MSI high, they're going to be a low risk, and you're probably going to recommend observation. But for this group in the middle, which is probably 3 out of 4 patients, then the Oncotype test can help us prognosticate in terms of the risk of recurrence at 3 years, which could be helpful to the discussion we have with our patients. And this is how they report it. You get an MMR, you get the MMR testing along with the Oncotype DX automatically, and that will be reported separately, as shown here. This is an MMR proficient sample, and then it reports the recurrence score on the graph. So this is a survey that was actually done by Genomic Health of a number of physicians who had used Oncotype DX in more than 3 patients, and then they were surveyed to go back to the chart and look at how the test helped them out and what their pre-test recommendation was compared to their post-test recommendation. So the pre-test recommendations are here: 40 out of 92, 40 observation, 19 fluoropyrimidine alone, and 33 FOLFOX. And afterwards, it landed up being 45 observation, 21 fluoropyrimidine, and 26 with oxaliplatin. So what happened if the blue ones are people who kind of downshifted in terms of the treatment, and the gold are people who went to more intensive treatment. And this is, there are 18 patients here and 9 there. So overall, 9 people got less treatment, and people were kind of resorted out to a certain extent as well. But you can see that in this case, it was mainly helpful in patients being treated less aggressively once the recurrence score had shown a low risk. And then I wanted to review the data that were presented at ASGIO this year by Mike O'Connell from NSABP CO7. So if everybody remembers, CO7 was the trial that looked at the Roswell Park 5-FU leucovorin compared to 5-FU leucovorin with oxaliplatin, which they call FLOX. And again, that's not exactly FOLFOX, that's weekly high-dose leucovorin with 5-FU, and then the oxaliplatin being given every 2 weeks, times 3, and then 1 week off. And so this study was really undertaken to help give more information about people actually being treated, because, as we said, the other data were really patients who were just getting treated with surgery alone, and how the recurrence score could be predictive. So this is really trying to give more information on the benefit of the chemotherapy with and without oxaliplatin. So again, compared to this flow chart I showed you before, now we've added this clinical validation study of NSABP CO7 with 892 patients. Again, as I said, it was the phase 3 intergroup trial. We already kind of went over that. And the primary objective was to determine whether there was a significant relationship between this recurrence score and the risk in stage 2 and 3 patients treated with 5-FU or FLOX. So as opposed to the other studies, everybody here was treated. Okay? And the way it worked, there were 2,400 patients. Almost 1,900 had available tumor tissue, and then half of these were taken for this original study in the study cohort, and the other half it will be further analyzed, which we'll eventually get the results of as a validation. So the patients were kind of split in half randomly to a developmental cohort and a validation cohort. So you can see here that the demographic and clinical patient characteristics are very similar in this 900 patient sample if they got 5FU or FLOX, and 30% were stage 2, 46% stage 3A and B, and 25% stage 3. The T4 stage 2 patients were 6% overall, and T3, T4 stage 3 were 85%. And you can see again, as one would tend to believe in this sample as well, 18% of the stage 2 patients had mismatch repair deficiency and 9% of stage 3. And these were similar to the entire group, so we think it's, it looks like this is a valid cohort to study. And here is, given these 900 patients, here are the outcomes for stage 2 and stage 3 with 5FU alone in the solid line and the dashed line for the FLOX regimen for stage 3 and stage 2. And this is reproducing what was seen in the full study. So we can see here now, if we look at this analysis of stage, treatment, and recurrence score in this CO7 data now with the 900 patients, you can see here that stage 3A and B versus stage 2 has a hazard ratio of 2.5, which is statistically significant. Stage 3C compared to T2 has more than a 5 times chance of recurrence. And treatment with oxaliplatin is just borderline significant with a hazard ratio of 0.76. And the recurrence score, again, turns out to be almost the hazard ratio of 2 per 25 units, and that is highly statistically significant. And furthermore, when you test for interaction with these other factors, there is no interaction statistically. So we can say that the recurrence score is an independent predictive factor and is independent from the stage or the treatment. So here are the graphs now using the recurrence score, and again, compared to the other graphs that I showed you, these are for patients who are all getting treated. In each case, the dotted line for stage 2, stage 3, and A and B, and stage 3C shows the effect of giving 5FU alone, the Roswell Park 5FU, and the solid line is the FLOX regimen. And in each case, the use of oxaliplatin reduces the risk of recurrence, even at the low recurrence scores. But down here, you can see, especially for stage 2 and stage 3, the benefit is not very great. So here's an example where you can go to your patient, and if they have a low score, saying, I can give you single-agent fluoropyrimidine, or I can give you oxaliplatin, but I don't really think oxaliplatin is going to help you that much. Whereas at the higher scores, you know they'll receive more benefit from the use of oxaliplatin. And if we look at them broken out into the groups by recurrence score, again, as I said before, low risk, less than 30, intermediate 30 to 40, and high risk, greater than 40, you can see here that for the 5FU and oxaliplatin, it's really no different in both the low and intermediate groups. But even for stage 2, you do get a rather substantial benefit here in the red for the high recurrence score. So people who had higher than 40 and got FLOX had a much lower 5-year recurrence risk than the people who got 5FU. Again, it's only about 9% compared to 23%. And in stage 3A and stage 3B, again, we don't see really any difference for the low-risk group. There is about a 10% difference for the intermediate group, shown in green, and then the red group, again, shows a nice 10% difference here. So the intermediate and the high-risk groups are benefiting from oxaliplatin in a clinically significant way for stage 3A and stage 3B. And for stage 3C, again, we see nice separation of the curves for the intermediate and the high group. The low-risk group is about the same again. But, given the fact that their overall risk is very high, about 40% of recurrence, whether you're going to not give them oxaliplatin or not would be your decision. So again, looking at this pre-specified multivariate analysis of some of the other factors besides stage, treatment, mismatch repair T-stage nodes, and tumor grade, we can see that there is a hazard ratio of 1.6 for the recurrence score. Tumor grade is borderline significant. The nodes, if it's fewer than 12 nodes, is significant. T-stage is significant. The mismatch repair enzyme is quite significant, and the stage is significant. And if you look at one of the secondary endpoints is to look at the effect of overall survival as well as disease-free survival, and the hazard ratio in the multivariate analysis is really quite similar. And so, this would suggest that these scores can be predictive of overall survival as well as the 5-year disease-free survival, which is what you find reported on the graph. So this is a conclusion from Dr. O'Connell and his co-investigators that the recurrence score was validated as a predictor of recurrence. It was the first prospective study in patients with stage 3, consistent results in stage 2 across 3 prospective studies, so this was no different than the other stage 2 trials, and that basically you can use this for prognostication and risk stratification so that you can have a better discussion of the risks and benefits of treatment with the patients. And so if we add that to kind of the stage 2 paradigm, what we might see is that for stage 3 then, if it's stage 3C, the risk is pretty high, you're really going to recommend FOLFOX usually, unless they have a contraindication to oxaliplatin. But in stage 3A and 3B, you may want to send the Oncotype test to help inform you and the patient more about the relative benefit of the oxaliplatin added to the single agent fluoropyrimidine, and perhaps in some of those patients you would give less intensive treatment with the use of FOLFOX compared to single agent fluoropyrimidine. So I will end there, and thank you.